We'll turn the floor over to our amazing neurologist, host, facilitator, Dr. Subramanian.
Hi, everyone. Welcome. It's almost the weekend, and I hope everyone's staying safe and doing well. And we are still physically, unfortunately, distanced, but socially connecting through this virtual modality. And thank you to the PMD Alliance for hosting. And it's with great pleasure that I bring you a fellow colleague who also is based here in Southern California, Dr. Litvan, and I'll be introducing her in a minute. She has been in a number of parts of the US before, and I have a lot of close friends that have worked with her before, and she just brings such a wealth of information, and it's been just nice to collaborate with her down here. And this is a talk that's from a lot of what people have asked for through the series. So they've been asking for an understanding of, if it's not Parkinson's disease, what else could it be? And so we'll be covering some of the atypical Parkinson's syndromes, or there's Parkinson's. So there's many ways that we talk about this umbrella of Parkinsonism, and Dr. Litvan will be telling us a little bit about that. She has a really interesting background. She's sort of been all over the world. She is originally from Uruguay, and then she did her medical degree there, and then did some training in Georgetown University in Washington, D.C., and also spent time in Barcelona, did a fellowship in Barcelona, Spain, so it's just a real wealth of information that she brings, and she's really been heading up a huge number. I was looking at her CV. She just has such a wealth of research talents, and has really been bringing together people to study many of the disorders that she'll be talking about today. So I wanted to introduce you and welcome you, Dr. Litvan, and learn a little bit about your journey. Maybe you could tell us a little bit about how you started in Uruguay, ended up in Barcelona, and now in sunny Southern California. What brought you to medicine originally? Maybe what inspired you as a neurologist, and also what made you interested in specifically these sorts of disorders?
Well, I love to help out, and so I always felt that being a physician was kind of something that I wanted to do, or being a nurse, either one. And as I grew up, I started to look at the brain, and I was fascinated with the idea that there were different areas in the brain, and that each one would have different functions, and that when there would be a problem, a lesion, then the person would not have that function. And I thought that was important. And more importantly, I thought, well, perhaps we can do something to make things better. And that's kind of how I got into research. So yes, I was born in Uruguay, and I did finish my medical school, but there was a dictatorship that came in. So I moved to Spain. But in Spain, they just were coming out of another dictatorship that was Franco. And so there was a lot of revolution in some ways. And eventually everything came was well. And I had a wonderful time being a fellow over there, and first obviously doing my residency, and then doing my fellowship in the best hospital in Spain, in Barcelona. So when I finished, I realized that I wanted to do research, and I thought that the US was the right place. So I came to the National Institutes of Health, and I spent many, many years there working. And it came to a point that they told me, if you really want to grow further, you have to go to academia. And so there was a position in Kentucky, and I thought, okay, I'm going to go there and start something. I had no idea where Kentucky was, I have to admit. So it was a whole new thing for me. And so I ended up in Louisville, at the University of Louisville. And there I established a whole movement disorder center, and I adjusted very well to the city. I was really very happy. And the people from the University of California told me, why don't you come and establish the same here? And I thought, oh, I'm not sure. I want to start all over again. But they said, just come and see. Once I came here and I saw San Diego, I said, yes, I'm coming here. I love it. So I came back to San Diego and established a whole movement disorder center that I'm very happy because now is a Parkinson's Foundation Center of Excellence. It is a Cure PSP Center of Care. It is a research center for dementia with Lewy Bodies. It is a Huntington's disease center. We work on dystonia. So it is a whole thing of things happen that we were able to grow and be successful. And I'm really happy with my patients that give me the strength to move forward and all the inspiration that makes me move towards doing more research so I can help more.
That's amazing. I think you could go to Mars and start a center and you'd have Huntington's and every other, so you can just so, we've had a really great run of powerful women in movement disorders, and I'm proud to say that you're one of them. We had Claudia Trenkwalder on earlier for World Brain Day, and she talked about the Movement Disorder Society, which I know you're a fellow in as well. And so we applaud the work, and it is a lot of work to succeed in this field and put together these things. But I'm inspired by your inspiring story, and it sounds like we're all really inspired by our patients. So I think without further ado, we will let you teach us a little bit about this field. I know you put together some slides, and we can kind of start there and take some questions as we go and learn a little bit more about, what you do.
Thank you. So I'll talk about why don't I have PD? That is a question that some of my patients ask. They said, I'm slow, I'm stiff, I have tremors, so why is it that I don't have PD? These are my disclosures.
We're just going to share the screen, right? We have to put up the slides.
Oh, I thought that, I'm sorry, I thought that is you disconnected me from the slides, I thought I was sharing them again.
Yeah, you just have to go at the bottom and share the screen.
Yeah, I'm doing that.
There you go, perfect. Yeah, we got it now.
Okay, all right, lovely. So hold on a second. Wow.
Yep.
So I start here. So this is lovely San Diego. So these are my disclosures. Most of them are related to research and really or therapeutic trials, and very little is related to industry. So the key points of today are, let's define what Parkinsonism is so we can understand what the Parkinsonian disorders are, and let's see how we can classify these disorders. Let's also talk about atypical Parkinsonian disorders and differentiate Parkinson's from all the atypical Parkinsonian disorders. I'll give a few examples at the end. If I go too long, you let me know, okay? So the most important aspect or the most important feature of Parkinsonism is slowness or slow loss of amplitude of the movement. That you'll see an example in a second. It is also the presence of either stiffness or tremor. And this is a patient that is doing the finger tapping that many of you may have done. And you can see that there is slowness, and at times there is kind of hard to see. Okay, let me go from the beginning here. These ones are starting on their own. So this is a patient that has a rest tremor, and you can see it here. And when he's moving his arms, that is going to disappear. And that is typical of Parkinsonism. The slowness can be also shown as we walk. And so this is a person that is very slow, and it is also having no movements of the arms, and the steps are kind of small. And that is a little bit of what Parkinsonian gait is. So all these disorders that are Parkinsonian disorders have something in common. And what they have in common is, like, in the back of the brain, you may have heard about something that is called the substantia nigra. That is what produces the chemical dopamine that makes the motor circuit work. Dopamine is like gas for a car. Without it, it doesn't work well. So what happens is that dopamine goes to these areas of the brain and then makes it the whole circuit in order to be able to allow us to walk well. And you may have heard of DAT scans. And so some people say, okay, if I get a DAT scan, will I be able to know what I have? Well, you would know that you have Parkinsonism, but it doesn't really tell you what disease you have. So as you see these areas in the brain, the nuclei, you can see here the same thing. And this is a normal cortex, that is the deep area in the brain. And this one is an abnormal one. You can see that there is something that is missing here that is related to lack of chemical dopamine that comes to the brain. So what are the Parkinsonian disorders? Well, these are diseases in which we have Parkinsonism. And we basically divide them in two major groups. Secondary to a cause that we can identify. And that's why we ask you, what are your medications? Have you had a little stroke? Have you had some infections, et cetera, because these kind of help us figure out if there is something that we can identify and treat right away. But if there is nothing like that, and the disease is kind of presents gradually and slowly, pretty much is what happens when we have a neurodegenerative disease. It's a big fancy name to basically say that cells in the brain die, and die much earlier when they should as we age. So all these diseases that are neurodegenerative can be divided in two main ones: Parkinson's disease, and these ones that are called atypical Parkinsonian disorders. And there are many. There are sporadic diseases that don't have family members with the illness, and that is progressive supranuclear palsy, PSP, that is something more known as PSP, multiple system atrophy, MSA, corticobasal degeneration, CBD, dementia with Lewy bodies, DLB or Lewy body disease. And then there are familial diseases like frontotemporal dementia with Parkinsonism. This is just to let you know. It's not that you need to learn all these fancy names. So the important aspect here of knowing what disease is what allows us to know what is the protein that deposits into the brain. The protein that deposits into the brain in Parkinson's disease, in multiple system atrophy, and in Lewy body dementia is called alpha-synuclein. This protein is very important, but what is more important is that it allows us to diagnose a disease if we do newer studies that are to look at the spinal fluid and measure alpha-synuclein. This is still not available for commercial, but it is in research and likely is going to go into the market. But in addition, and more importantly, is that we can develop, and we are developing, treatments to try to slow all these diseases that have alpha-synuclein. So if we know that is one of these three diseases, perhaps we can try to find eventually a treatment that can slow or stop the illness. The other protein that deposits in PSP and in CBD is called tau. Tau is another protein that is kind of what forms the walls of the cells, the walls of the pipes that nourish the cells. And if it's not functioning well, of course, the cell is gonna die, and that is pretty much what happens. And again, we're having multiple treatments that are being looked at to try to see if any of them can help slow these diseases. There are these other ones, several other ones that I'm not going to mention because I'm not going to discuss them, and that have other proteins, and we don't have treatments for those yet experimentally. So what is an atypical Parkinsonism? So while we can define Parkinson's disease as having the slowness with or without tremor or rigidity, the typical Parkinsonian disorders have more than that. They have early on problems with walking, problems with balance, and in addition, they have problems that do not occur in people that have Parkinson's disease. So I'm gonna tell you what are the differences between one and another, although I'm not gonna be able to go over all the differences, but I'm gonna go into several so you can get a sense of what's going on. So if we give a person that has Parkinson's levodopa or Requip or pramipexole, whatever it is that you administer, it makes all this motorcycle that I told you work because it's replacing that dopamine that we normally have. So the patients respond beautifully because that is a major aspect of the motor problems that patients with Parkinson's have. They don't have so many other problems regarding motor problems. There are other problems without any doubt. And as the disease progresses, some of the things that happens in atypical Parkinsonian disorders may happen in Parkinson's. But one thing that does not happen is what happens in the typical Parkinsonian disorders. There is lack of benefit. There is no benefit. The person stays about the same. Initially may respond minimally or mildly, but not a major benefit as we see with Parkinson's disease. Another difference is that while in Parkinson's, the disease progresses in a slow way, this does not happen with the typical Parkinsonian disorders. For example, early on, we can have problems with balance, people that just fall without knowing why they fall, because there is not that they had an accident, there's not that they didn't see something, or have other clearly problems, such as having problems with the knees or the hip or something that would explain that fall, then those people may have what we call one of the symptoms of the atypical Parkinsonian disorders. In Parkinson's, on the other hand, as you saw in that patient that I showed you earlier, they may walk slowly, may have slow steps, but there are no problems with balance or fall for many years. So here you can see a patient of mine who actually was not walking so bad, but she has an abnormal posture, and also she has no balance. As I minimally touch her, she falls and she cannot recover. She also has the skin with a red color that if she puts the legs horizontally, that disappears. That is, those are the symptoms that have to do, this one in particular, with the autonomic system, and I'll talk about that later on. What are the differences? So another difference is that patients with the other Parkinsonian disorders may walk like if they were inebriated. This is not the one I wanted to show you, so let me show you the one I wanted to show you. I'll go back to the other one. So you can see that this person is unstable, but also when the legs are really separated from each other. At times it's hard to see, but you clearly can see that overall the legs are separated. And that is not something that we see in Parkinson's disease. Let me go backwards now. Freezing can occur in Parkinson's disease, usually does not occur early, but this patient had freezing for many, many years and ended up having another disease that is PSP. So it is a different story altogether because freezing, walking was her major problem. She didn't have any other problem. Freezing was it. So we talked about the rapid progression. So one of the things that could happen is that we can see a patient early on coming in a wheelchair and having like a fracture, and that kind of let us know that this patient does not have Parkinson's. So we already know as the patient comes into the office that this is not Parkinson's disease. Again, there is a slow progression in Parkinson's disease, so we don't see many people walking with going into a wheelchair. And if they do, is when the disease is quite advanced and they may come in a wheelchair, but then they leave walking normally because now the levodopa is working, or the another medication that makes the motor circle work. So in these atypical Parkinsonian disorders, there are problems moving the eyes. It could be up and down, it could be horizontally. There is also a clear difficulty with reading that is beyond of what we have as we age. And that doesn't happen in Parkinson's disease. And I'm going to show you a little bit of a patient that had PSP. And he was able to follow horizontally that pen, but you're going to see that he's unable to follow it in the vertical direction. And that is why the disease is called supranuclear palsy, because there are lesions that are above of where the nuclei, the areas for the nerves that go to the eye are, and make both eyes not being able to move appropriately. And we can confirm it because if we move the head up and down, we can see that the eyes move like you would see in a doll's. And that is what we call the doll's head maneuver. He wants to see his watch, but he's unable to do so. And the same, perhaps moving the eyes, but not really like that because they go up. But in any case, moving his arm is how he's going to truly see it. There could be that the person has a stiffness. I may say that they have tremor when not doing anything, as we saw, tremor at rest in the patient with Parkinson's disease, being slow. But in the typical Parkinsonian disorders, there may be a lack of ability to use a hand or a leg, or there could be difficulty having special abnormal postures. And here, actually, this patient of mine was a policeman who had lost the ability of using his gun. And that was his first symptom. And then he developed these abnormal movements that you saw. And there are several here. The difficulty that he has extending his arms and how he has his fingers, and also that little jump that he has, none of that we usually see in Parkinson's. However, I'm gonna clarify something. In people that have young Parkinson's disease, at times we do see this abnormal posture, what we call dystonia, and that improves with the levodopa, the dopamine agonist, but this one that this patient has does not improve with anything, so it's a different one. It could be that patients may have dementia early on. They may see things that are not there. They may have problems talking, may find a significant difficulty saying words. And that is not what happens in Parkinson's. In Parkinson's, the cognition in general is normal. There may be some difficulties multitasking or perhaps planning. There can be some depression, some anxiety, but unless they have some medications, they don't have hallucinations. The hallucinations that we see in atypical Parkinsonian disorders are hallucinations without any medication whatsoever or any reason whatsoever.
Is that scary for you in some ways?
No, that's sort of interesting. I'd like to see what's going on.
Okay. What are the interesting things you see?
Well, faces and colors and things that are attractive to me.
People that you know?
Yeah, sometimes, and other times people that I can't recognize.
Okay.
So you saw that. This was a patient that had dementia with Lewy bodies, and we'll talk about that briefly later. And hallucinations early on without any medication or any reason may occur early on. So on the other hand, here we have that in Parkinson's disease, people act out the dreams. Normally, when we sleep, we don't move when we dream. But what happens in Parkinson's is that we can act out the dreams. And if the dreams are really bad, then we're trying to defend ourselves because we don't want to be attacked. And then we can either hurt someone or fall to the floor or hurt ourselves in different ways. That is not usually present in the typical Parkinsonian disorders. And I'm going to show you this because actually this is one of the early signs of Parkinson's disease. This may not happen on everybody, but may happen many, many years before someone develops Parkinson's disease. So he's having a bad dream and obviously is trying to defend himself. So this is why he's doing this. At times the patient may awake and at times continue sleeping, and in this case also continue sleeping. So now let me summarize a little bit and give you a little bit of a glimpse of what is what are the features of some of these disorders. And I'm starting with PSP because it's the most common one. So these patients present with early balance problems and falls. That is extremely common. They may have this Parkinsonism, the slowness, the stiffness, but usually instead of being a lot on the limbs, as in Parkinson's, it's more on the axial areas. It's more in the walking, it's more related to the neck, areas that are completely different. In addition, as I mentioned, these patients unfortunately do not benefit from the dopamine medication, and they don't benefit because not only that lesion that I show you initially was present, the substantia nigra lesion that leads to not having dopamine, but there are also lesions in other areas of the brain that are part of that motor circle. Therefore, if we give dopamine, it's not good enough. And this would be like, you know, if the problem is that you don't have gas and you don't have oil, you can put gas, but if there is no oil, the car is not going to work. And here is something like that. The only problem is that we don't know what are the other chemicals that we would need to use. In this case, as the patient that I showed you before, there is difficulty moving the eyes. And at times this is the first problem, but most of the patients don't have that. And there is problems with the speech. It's like it comes difficult in enunciate the words. And there may be problems swallowing. And at times, there is a more significant, and that is common actually, to have much more difficulty with what we call the frontal lobe. That is the areas in the brain that pretty much coordinate the rest of the brain. It's kind of the conductor of the brain. And so that's why these functions are called executive, because it is like an executive functioning, that is problems planning, problems multitasking. So these things that an executive would do.
Your main problems?
Well, I fall a lot, and I lose my balance, and I don't have any speech, and I write terrible.
What was the first problem you had?
Falling.
So that's kind of the typical history of a patient with PSP. So now a glimpse of multiple system atrophy. So the major problem in this disease is the autonomic system that is having lesions. And the autonomic system is pretty much the nerves that go to the different organs. So that's why the urine is one of the function of the urinary system is one of the problems. And so there could be some urgency and eventually incontinence or retention of urine without having any prostate problems. There could be erectile dysfunction, and there could be as well a drop of the blood pressure when standing. And that can be very, very significant and give a lot of problems, being extremely fatigued, having pain in the back of the neck, feeling like you're gonna faint, or fainting, having a syncopal event. So if in addition we have the other features that we talk about Parkinsonism, then this is multiple system atrophy with Parkinsonism. MSAP is called. And it has all the features that we just went over. On the other hand, if they have cerebellar problems, that is that inebriated walk, being extremely incoordinated and having problems with speech, then we have multiple system atrophy with cerebellar symptoms. And I'm going to show you a little bit of this.
That off and on problems with incontinence.
Impotence, was that a problem also?
No problem.
Feeling woozy?
That's not been much of a problem.
Your blood pressure was, when you were lying down, 167/79. But then when you got up, your blood pressure came to be 95/59. So it really, there is a
It
big
fluctuated a lot.
So people think, oh, it's fluctuations, but reality is that the blood pressure drops in significant ways, and that's why not enough blood goes to the brain, and so the person has all these symptoms. So that is kind of a speech that is different that occurs in cerebellar disorders. And this patient in 4 years went from walking to being wheelchair bound. So this patient has the incoordination that I was trying to tell you that is a little bit different than the tremor itself. If you see, there is a little bit of difficulty that goes beyond, and it's difficult at times for her to find where is that, that finger. That is different than a real tremor. So what happens with dementia with Lewy bodies? Well, the major problem is the dementia. That could be just what we said before, having problems that are executive, having fluctuations, like one day I'm functioning beautifully, and the other day I'm so confused that it's really hard. Seeing things that are not there, not related to medication, having Parkinsonism, and here is also enacting the dreams. So in summary, Parkinsonism is a combination of slowness, stiffness, tremor, and balance problems. But persons with the atypical Parkinsonian disorders have that Parkinsonism plus other problems that patients with Parkinson's do not have. And I briefly pointed the problems that persons with PSP, MSA, and DLB that are the most frequent atypical Parkinsonian disorders have. So thank you very much.
Thank you. That was great. So let's maybe just, we can stop sharing those slides and we can reconnect. That's perfect. So we have a number of questions, Irene. I think it was a really thorough presentation, and just so I can summarize a little bit. So it sounds like, you know, the ways that we can approach Parkinson's patients. So there's this umbrella of people that look like Parkinsonian. So they're stiff and sometimes, you know, slow, and sometimes have a tremor. But then there's these other things that kind of are red flags as doctors that should point us in a direction that might be different than Parkinson's disease. One of them is that the response to medications with classic Parkinson's is quite robust. Many symptoms do respond really, really well to levodopa, and that response lasts for many, many years. With the atypical Parkinson's, it sounds like that's not the case. And we can, some of the questions ask about the response to levodopa, so we'll clarify. Then there's a number of things I wrote down that kind of are red flags, like you said, the wide base gait early on, eye movement issues early on where we can't look up, especially, or down. When the hand gets dystonic or tight early on and not responsive to medications. Early cognitive changes, early hallucinations that are early, like in the first couple of years of the Parkinson's, early falling. So if somebody presents to a doctor and they're falling, like one of your patients on the video, right at the beginning, then we start questioning, is this actually regular Parkinson's disease? And then it sounds like early speech problems and swallowing problems. So these are usually not things we see in classic idiopathic Parkinson's disease early on. So if you have these things and you're seeing a doctor and you're not really responding to medication and you're feeling like you might have got the diagnosis of Parkinson's disease, maybe revisit that and maybe try to see some, you know, expert, maybe like a movement disorder specialist or definitely a neurologist if you're not seeing one, so that you can get a little bit more guidance. Does that sound about right?
Absolutely, yes. And I see some of the questions.
Yeah, I can kind of, I can sort those out. Don't worry about those. So one of the questions, just to clarify, because there were some words I think early on, one of the questions was, where do things like dopa responsive dystonia fit in the classification? Another question was about vascular Parkinsonism. Where does that fit in this sort of stuff? And then one of the questions was also about clarifying what familial is, because it was on one of your slides. So maybe we can find out about dopa responsive and vascular Parkinsonism. Where would those fit?
So in Parkinson's disease, particularly early on, you may have an abnormal posture of the hand, and you may have an abnormal posture of the leg when you walk. And at times it's when you walk a lot, at times it's only when you're running. And eventually, when we adjust the medications, that abnormal posture goes away the majority of the times. It could be that some people may not, but in general, it goes away. And the person has many, many years doing very, very well. That, by the way, the dopamine response in Parkinson's is forever. It may well be that because this certain medications such as Sinemet doesn't last long, then initially it may happen that we have other neurons that are storing the dopamine, and so it may last many, many hours. But because the levodopa lasts normally, as in Sinemet, an hour and a half, when the disease progresses, then the medication lasts less. But this is not a problem that the disease makes it not to work. The problem in the majority of the situations is that the medication doesn't last enough. So there are newer medications that last longer, such as Rytary, for example, and then that happens much, much later because the Rytary lasts 5 hours, as an example. So that I wanted to mention, because many people read in the internet that, oh, you try levodopa and then it goes, you know, you end up not functioning. It doesn't work. Yes, it always works. It just happens to be that it works for less amount of time. So that was related to, unrelated to what I was asked. The first one was the dystonia. And what was the second one?
Vascular. So there was dopa responsive dystonia and then vascular.
Okay, so the levodopa response dystonia is what I just explained before. That is the dystonia that responds to Sinemet or levodopa, or dopamine agonists like Requip, pramipexole. All right, so vascular Parkinsonism is in fact one of the secondary disorders because we have a cause, and the cause is the multiple strokes that lead to that Parkinsonism. So as I mentioned before, there are certain areas of the brain that lead to a function. So if we have a stroke in the area that has to do with language, we may not be able to speak well. Here, if we have little strokes in the areas that had to do with the motor circle, then we may not be able to function as normally, and we would become having vascular Parkinsonism. The vascular Parkinsonism, I didn't talk, but the person walks with wide gait with the legs separated, as I showed you before in the inebriated. There is postural instability, and the problems are mostly in the legs. The arms are pretty good. That is very different than in Parkinson's, that the arm and the leg, or in the typical Parkinsonian disorders, that eventually the arm and the leg are affected. So that goes for vascular Parkinsonism. We can diagnose that based on the history, based on MRIs, when we do an MRI of the brain.
Okay.
And the treatment is mostly physical therapy, just in case. Go ahead.
Okay, perfect. There's just a clarification or two about other syndromes. This is a very educated bunch, so they've been watching a lot of these videos just to, you know, so they were just asking about REM behavior disorder because we had a speaker just speaking about that, and they know that it's also sometimes seen, and you mentioned this also in Lewy body disease.
Yes.
And there's also a question about whether that can be seen in multiple system atrophy as well.
Yes, absolutely. I'm sorry. I think I was misleading you on that one, and that was my error, because I was thinking mostly on PSP and in corticobasal degeneration, where that does not occur. But certainly in dementia with Lewy bodies and in multiple system atrophy, those are also that are the diseases that have problems with deposits of alpha-synuclein. In all those diseases, REM behavior disorder occurs. That is the enacting of the dreams.
Perfect. And you showed us that beautiful video. That's so interesting. So there's been a few questions about sort of early on in presentation, whether sometimes Cinemet is added and sometimes people can have a response and then maybe they lose that response. The question is, you know, is there actually response? Is there a placebo effect? Should people get off the levodopa if after some time, if they end up feeling like, you know, maybe they didn't end up having Parkinson's? Sort of what's your sense of that?
Well, what happens is that when we give the levodopa and someone does beautifully, this is because we're giving the chemical that is needed to make the motor circle work. So if we take it away, the motor circle is not going to work. This is like, you know, saying, well, is gas for a car a placebo effect? No, it isn't. If you don't put gas, it doesn't work, period. And here it is the same. We have a decrease on the amount of dopamine, and the levodopa converts into dopamine. So it is very important to continue the medication. It is like for people that have diabetes, they have to, when they use insulin in general, particularly those that have diabetes when they are kids or very young, they have to use insulin all their lives. So there are certain things that you feel great, but you're feeling great because you're taking medication, which is really a blessing. To be able to do well with medication.
Okay, that sounds good. So there's a question about, I guess it's sort of more like a biomarker question. We've had, actually Chuck Adler came on and talked about some of his studies with Parkinson's and even the brain donation. He gave a really nice talk for us. There's been a question about whether skin biopsies and other biopsies in the Parkinson's plus disorders might be helpful.
Not yet. These are things that are being experimental and are being used, but still we don't have real good ways of making diagnosis in that way. However, while we cannot do that, I mean, the problem is that the typical Parkinsonian disorders, there are different proteins. It's not just one as in Parkinson's, and so you can generalize. But in some of the Parkinsonian disorders, such as PSP and corticobasal degenerations, there are ligands that bind to the proteins in the brain that have tau, and we can see those in PET scans, as we can see the amyloid in Alzheimer's disease. So it is still a question of being exploratory and in research, but more and more there are better ligands that are allowing us to see much better the brain. So eventually we may be able to diagnose early these two diseases by using a PET scan. Not yet.
Okay.
That doesn't occur for Parkinson's or MSA. Go ahead.
So a question, just, I think there's been an interest in learning a little bit about research, and what are your most exciting kind of prospects in terms of the research that's happening in this area for patients with atypical Parkinson syndromes?
So the most exciting thing for me is to see that we are starting to have treatments for patients that have the atypical Parkinsonian disorders. So we are doing a lot of treatments for patients that have PSP because we can diagnose them very, very well. It may take us a little bit to diagnose them. It will be better once we have the PET scan with that ligand for tau, but we can diagnose them well. So industry, instead of using so much all these efforts in treating Alzheimer's disease, realize that in PSP, there is only one protein that deposits into the brain, and it may well be much easier to find a solution than in Alzheimer's that has two proteins, tau and beta amyloid. So there are many studies, and one of them we just finished two of them that unfortunately didn't work, but we're having a third one that is coming up, that is antibodies against the tau. So I don't know if you went over some of these things or not, but the disease progresses going from one cell to another. Did you go over all that? Because I don't want to repeat.
No, not about the atypicals, but in Parkinson's, we have talked, Dr. Lang came on and talked about the alpha-synuclein type antibody treatments. And then Alberto gave a very complicated talk on, how a lot of the pathology may not have anything to do with actually the way that, so we've had a lot of different people that have talked about things, but if you'd like to describe that for a minute or two, we have about 5 minutes left. So happy to have you, teach us a little bit about that.
So what happens in PSP, as in Parkinson's disease, is that several studies in animal models have shown that if you put the brain of a person that had the disease and you put those areas that were affected into a mouse, the mouse develops the exact same lesion that occurs in the human person, and also starts to go from one cell to another and spreads. So it became clear then that the disease goes from one cell to another. How does that happen? So what happens is that the protein kind of falls in abnormal shapes, and because of that, the functions change in the cell and they start to bind to each other. And when they bind to each other, eventually they go with, and because they still communicate, they are sick but not dead, the proteins can go from one neuron to another neuron. So the idea of antibodies is to use the antibodies to try to rescue, or actually to get rid of, more than to rescue, to get rid of all these abnormal proteins that deposit into the brain and get them out. Of course, not all of them are going to be gone, but the important part here is that we take away the part of the protein that is abnormal and is the one that leads to the spread. And apparently the antibodies that we just finished using that fail, unfortunately, went to the part of the tau protein that actually was not the responsible of moving from one cell to another.
Okay, so it sounds like there's clumping, there's proteins that are folding weirdly, they clump together, then they affect the cells near them to make them also fold weirdly and clump abnormally. So we're trying to attack some part of the protein that is responsible for this spreading and bad clumping, but we haven't quite found exactly where to attack. And we're looking for the right place for the antibody to be attacking. And so you have some hope that we can do this in not only possibly Parkinson's, like Dr. Lang was talking about, but also in things that affect the other protein, which is the tau protein, like in PSP. So that's really exciting. So I think we have 2 minutes, Irene. I was hoping to just have you give some hope and sort of a message of closure for our group here. There's a lot of activists, a lot of people who want to get involved in research. And so maybe you could just tell us about, what you think would be sort of the best way for them to kind of improve their outcome.
Well, I think research is the best thing that can happen, and particularly at this time is, and in particular in Parkinson's disease more than any other disease, I think it is the best time because of 3 things. One is that we saw in patients that the symptoms precede the development of the non-motor symptoms, such as depression, the REM behavior disorder, constipation, etc. All those develop years, lack of smell, years before the motor symptoms. So that shows what are the areas affected, and that they are affected very early. And there is a phenomenal study that show using different PET scans for the different chemicals that are in the different areas of the brain, how patients that had only REM behavior disorder compared to those that had Parkinson's disease, they had all these same areas affected, except those that had to do with the motor system. So it is clear how the disease is progressing. And then when we look at pathology, the same happens. So I think that this is kind of and if we do experiments, as the one that I mentioned for PSP and corticobasal degeneration, if we do experiments with a brain of somebody that had Parkinson's and we put it into a mice, and the disease has the same lesion and spreads. So we have evidence from pathology, we have evidence from the clinical symptoms, and we have evidence from the physiology that all that is going in the same direction. This is the first time that we can see how all the research is showing us a path. So now it comes our time to try to search for what is the medication that would be the best one. And there are several opportunities, multiple in fact. One of them is the antibodies. Another one is to act over the proteins that are abnormal. So there's genetic ways nowadays that are being experimented in animal models. So I think that it is extremely exciting to see that finally It's not just that we do this little treatment, but we don't know much about it. It's just that we saw that there was oxidation, and so we use an antioxidant. We saw this and we use that. Here, there is a whole amount of data that are going in the same direction. So it seems like we're on the right path. And that is something that is, for me at least, I never thought I would see all this. So I'm very, very excited as well. So how can you help? Well, there are multiple ways in which you can help. You can help participating in research. You can help by spreading the voice about the disease and making people aware that it exists. Many people, I would say incredible amount of people, have no idea that this disease exists, or even that Parkinson's can be treated, or even that Parkinson's are not people that the first year of the disease are going to be wheelchair bound. So when we give the diagnosis to someone that they have Parkinson's disease, it's almost like giving the diagnosis of having cancer, that you have just a very short period of time to live and your life came apart. And I think, fortunately, there are several ways of improving that. So educating is extremely important. And then lobbying. You can lobby with your congressman and just say, we want funding for our disease. More funding is needed, as there is funding that goes to research with Alzheimer's. We want also funding to go to research such as Parkinson's disease. So there's a myriad of ways. And of course, donating the brain when the time comes is another way. So I can't stress so much more how you and us can go together and being really trying to search for ways in which we can improve the care of these diseases and hopefully diagnose them early and hopefully finding a treatment that stop them, or diagnosing them so early that perhaps we have REM behavior disorder and that's about it. That would be lovely.
Absolutely. Well, that's very inspirational. Irene, there's been a lot of positive comments. They want you back. They want to do 2 hours with you next time or something. I don't know. It's like we could spend all day on here, but such an interesting area and so much hope and research going on, and you're leading so much of it. So I'm so proud of you and continue to be inspired by you. So thank you so much for spending the time. I know you're very busy, and I'll hand it back to you, Andrea, for our goodbye wave.
Yes.
Thank you so much for inviting me. It was lovely to be with all of you and to receive all these very intelligent questions.
Very good. Well, we always show our gratitude with a wave. So if you put your camera on and if you switch it to gallery view, you can scroll through, and if everyone can show their appreciation for Dr. Litvan and, as always, Dr. Subramanian. Thank you everyone for joining. Great questions. This was excellent to spend this hour learning with all of you. Bye now.
Thanks, Irene.
Lovely. Bye-bye.